Functional movement disorders. In the last video, we talked about some boundary cases between psychology and neuroscience. We mentioned that in Parkinson's disease, or in patients who have had a stroke, you can see the symptoms directly in brain scans. But with neuroimaging technology getting better and better, we can also see altered patterns of brain activity in those experiencing depression and phobia. So does that mean that these are also brain diseases? The answer is actually a bit controversial. Some psychologists are in fact increasingly calling them brain diseases, but we like to think of this a little bit differently. Again, the hardware versus software analogy may be useful. If your computer is making an annoying beeping sound every time you open your browser, that is most likely a software problem. But it has a hardware correlate too, which you can measure from the speaker. Still, to fix it, you may be better off going the software route. Of course, you can try going the hardware route as well by turning off the speaker, but that might not be a good idea because you lose sound altogether. As you can see, there are advantages and disadvantages of treating a problem as only hardware or only software-based. Even if some psychologists think that depression and phobia have clear brain bases, these disorders are considered to be within the domain of psychology and psychiatry. Most of these patients wouldn't be treated by a neurologist or a neurosurgeon. But there are cases in which even the institutional boundaries aren't so clear in practice, meaning that sometimes the neurologist might think that it's a psychological problem while the psychologists think it's the other way around. One example is what is called functional movement disorders, also sometimes known as psychogenic movement disorders. These patients may show small, unwanted movements such as jerks or tics, which seem uncontrollable. That is, if you ask them, they will certainly say that they don't want to be making these movements. It all just seems to be involuntary. One may think that they should be treated by a neurologist. The problem is that the neurologist would often find that the movement pathway from the patient's brain to their spinal cord is actually fine. In fact, they can magnetically stimulate the motor cortex and see that the signal passes through the spinal cord and leads to an observable movement. This method of stimulating the brain using magnetism sounds cool, right? We'll talk about it more in the next class. And to complicate matters further, if you distract these patients, perhaps by making them focus on something important, these involuntary movements would sometimes cease. This is the sort of thing that really gets the neurologist to think, maybe this is psychological. And in fact, that's why they're called functional movement disorders. There is an apparent lack of structural problems along the motor pathway. The problem seems to be that the pathway does not function, even though we can't see the problem at the hardware level. But as a psychologist, you aren't really used to dealing with movement disorders. You may think, perhaps the patient is suffering from some form of epilepsy, but the epileptologist can monitor their brainwaves and find no signs of seizure. So what's going on? The short answer is, it's complicated. To understand this, we need to understand how the motor system works. Not just the anatomy, but also how it functions and how it relates to other psychological functions, such as attention. We'll learn more about this in class 2. This is one reason why functional movement disorders have been called a crisis for neurology. Sounds scary, but what it means is that the traditional ways of classifying problems into brain-based versus psychologically based sometimes just doesn't work. These patients are not necessarily suffering from psychological issues in the form of depression or anxiety, but this is not to say that psychological factors are irrelevant. To understand the disorder, to truly understand it, we often need to think both in terms of the brain and the mind. You may think that these are rare cases, but unfortunately they are very common. Often these poor patients are misdiagnosed or they get bounced back and forth from clinic to clinic because the different doctors think that it is a problem to be treated by a different specialist. This is why it's considered to be such a challenge. So perhaps this is another reason why, as a psychologist, you gotta know something about the brain. You often need to.